Hello everyone, today we'll be talking about work of breathing further and we'll talk about some clinical management in this regard. So from the previous lecture, we understood that the work of breathing is performed against elastic nature of lungs and airway resistance, where elastic work is dependent on your driving pressure and tidal volume, while the resistive work depends upon your airway diameter, flow rate, flow type, and the gas density. When your body's demand for oxygen or your respiratory stimulus for breathing increases, it can result in increased work of breathing. And the way your body will respond to it by increasing the driving pressure and thus increasing the tidal volume and the respiratory rates. So your body is trying to increase the oxygenation. However, your respiratory muscles are using more oxygen as well. Under normal breathing condition, your respiratory muscles use around 3 ml per minute of oxygen, while at higher workload, they need more oxygen and sometimes they can require up to 30% or more of the total oxygen requirement of your body. So you're called to evaluate a patient with increased work of breathing on the floor. What do you do next? One of the common mistakes a lot of medical personnel do is by trying to reduce their work of breathing by giving them opiates and benzos, because these patients are seemingly very anxious. But you have to understand that their work of breathing is a response from some underlying pathology, and your body is doing increased work of breathing to compensate for this pathology. So in a way, it is like a sinus tachycardia, where you don't treat the rate, you treat the underlying condition causing that tachycardia. So the anxiety occurs because your patient can't breathe. Hence, treat what's causing the increased work of breathing and dyspnea in your patient, and try to avoid treating anxiety with opiates or benzodiazepines. So as a rule, don't have anxiety as your first differential for increased work of breathing. Understand why your patient has increased work of breathing. Different pathologies would have different ways that they increase work of breathing. For example, in pneumonia, there is more elastic work of breathing because the lungs are more stiff. There can be secretions in the airways which can increase the resistance, and the patient is breathing at higher respiratory rate and tidal volumes from the acidosis, hypoxemia, and inflammation in the lungs. Patients with sepsis can have increased elastic work of breathing because of acute lung injury, and acidosis, hypoxemia, and inflammation can drive their respiratory rate and tidal volumes. Patients with COPD, they can air trap, so they can have higher elastic work of breathing, and they also have increased resistive work of breathing. On top of that, they will have dead space ventilation causing hypercapnia, thus increasing the respiratory rate, causing more air trapping. So try to understand why your patient has increased work of breathing and try to see how we can minimize this. Your job on the floor is to make the work of breathing more efficient, and if the patient is failing or tiring out, it's absolutely okay to go and control their airways and intubate them. Increased elastic work of breathing occurs because of increased lung stiffness, loss of surfactant, and breathing at higher lung volumes. So to reduce elastic work of breathing, treat the underlying cause. So for example, in patients with heart failure, use of diuretics will cause decreased pulmonary edema and reduced elasticity. Patients with ARDS and pneumonia, you can use low tidal volume ventilation and diuretics, trying to keep them more negative as tolerated. However, patient with pulmonary fibrosis, you cannot really do much except curb down their inflammation by using some steroids. One of the things that you can use in this patient is to use PEEP to recruit and prevent atelectasis. Atelectasis, as you know, can increase work of breathing because the diaphragm is suboptimally placed, and to obtain similar tidal volumes, your lungs have to increase their driving pressure and overstretch the normal lungs. You also have to increase the respiratory rate to compensate for the minute ventilation. Finding an optimal PEEP is really important because if you use too much PEEP, you can overdistend and can worsen the compliance and increase the work of breathing. And if you're using too little PEEP, you're not recruiting and you're not preventing cyclic atelectasis. So if you're ventilating somebody in VCAC mode, as you increase the PEEP and cause recruitment, you will see that the driving pressure does not change. However, if you continue to increase the PEEP and your driving pressure start increasing, that means you are overstretching. Check out my lecture on how to optimize PEEP to understand various ways to figure out optimal PEEP. In patients with increased lung stiffness, increasing rates is more efficient in minimizing work of breathing. This is one of the other reasons why you should use low tidal volumes and work on the rates to increase your minute ventilation. Whenever you do increase the rate, always watch for auto-PEEP. You also watch for auto-PEEP when you're dealing with obstructive processes. So how does auto-PEEP cause increased work of breathing? So we have got two lungs. We have got a normal lungs on the left and auto-PEEP on the right. Your atmospheric pressure relatively is 0. So at end expiration, the pressure in the alveoli is same as atmospheric pressure. So there is no airflow. Your intrapleural pressure is -3. If you have auto-PEEP, your pressure inside the alveoli is more positive, say for example +10 in this case. When you inspire, you generate -6 centimeter of intrapleural pressure, and in a normal alveoli, the pressure drops down to -3 centimeter, and the air can flow from the higher pressure to lower pressure. However, if you see the patients with auto-PEEP, their intra-alveolar pressure is still +7. It has dropped from 10, but it is still high, so no air can still flow. So to generate a flow, this patient has to perform a driving pressure of 13 centimeter of water to get negative pressure inside that alveoli. And still, even by doing so, it will take longer for the alveoli to fill because of the obstruction. So the tidal volumes obtained will be much lower than the patients with a normal alveoli. So auto-PEEP can cause significant increased work of breathing. And the way to deal with auto-PEEP is using PEEP to counter your auto-PEEP and to work on your respiratory rates. If you want to watch my lecture on PEEP, I have explained this in a little bit more detail. Positioning goes a long way in improving compliance of the lungs. Head of the bed elevation is the simplest thing that you can do. Whenever you raise the bed, your abdominal contents don't press against the diaphragm. There's less dependent atelectasis and there's more optimal diaphragmatic position. So head of the bed elevation is very important and simplest thing that you can do on the floors. Avoid wedging of the patient, especially in obese. A lot of time when the head of bed is elevated, the patients have slid down the bed and they are wedged in that angle, which compresses their abdominal contents and reduces their lung volumes. So try to pull them up so that they are in a more optimal position. In obese patients, I try to use a mild reverse Treadland-Burke position so that the pressure of the belly doesn't press against the diaphragm, so as to prevent atelectasis and give a little bit more optimal position for the diaphragm. Proning can also help improve compliance in multiple ways. We'll discuss about proning in some other lecture in more detail. But in short, it can decrease gravitational pressure on the heart and mediastinum on the lungs. It can decrease compressive effect of abdominal organs on the lungs, and there is a more homogeneous chest wall compliance due to restriction of anterior chest wall motion. Always monitor for extra-thoracic cause for increased stiffness, especially look for abdominal distension and abdominal compartment syndrome. Abdominal thoracic pressure transmission is about 50%, and increased abdominal pressure can push on the diaphragm and can decrease the chest wall compliance, lung volumes and functional residual capacity, and can cause increased atelectasis. Increased abdominal pressure do not affect the lung compliance, but what they do is decrease the chest wall compliance. Apart from treating abdominal compartment syndrome, if your patient is hypoxemic, you can use PEEP successfully to overcome the chest wall compliance and improve atelectasis. Always train the pleural effusions if you are dealing with increased work of breathing. Pleural effusion can reduce FRC. They can increase the elastance of the lungs because of distortion and atelectasis. They increase intrapleural pressure and your diaphragm lies in a very unfavorable position. You can see that as your pleural effusion volume increases, the compliance of the lungs worsens. Small effusions typically have no effect on respiratory mechanics. Removal of pleural effusion through thoracentesis does not always correlate with change in vital capacity or total lung capacity. In a study, they removed around 1 to 1.7 liters of pleural effusion, and they only found increase in vital capacity by 0.4 liters and total lung capacity ranging between 0.2 to 0.7 liters. The increase in volume does not correlate, as large part of the volume that is built up is because of the downward displacement of the diaphragm. Once thoracensis is performed, patient starts feeling better almost immediately, and this is because of decreased work of breathing, as their intrapleural pressures are better and their diaphragm is in much better position. Resistive work of breathing, depending on the diameter of airways, flow rate, whether the flow is laminar or turbulent, and length of the circuit. So to reduce resistive work of breathing, try to increase the airway diameter, try to increase laminar flow and reduce turbulent flow, and decrease the length of the respiratory circuit. Increasing airway diameter is mostly performed using bronchodilators, in which we use anticholinergics and beta-2 agonists, which can help relax the bronchial smooth muscles. Steroids can be used to reduce inflammation. And removal of secretions is really important because secretions reduce diameter and increase the turbulence. Use optimal size endotracheal tube for your patients. Using smaller tube will increase the resistance. Tube size less than 6 mm will have proportionately higher air resistance than the larger ones. In females, we typically use size 7 to 7.5, and in males, we typically use size 7.5 to 8. However, largest one can be used as well. One of the interesting thing to note is normal human respiratory tract has much lower resistance than even size 12 ET tube. You can use PEEP to reduce airway resistance, and you can use PEEP similarly to match the auto-PEEP to prevent the dynamic hyperinflation. To increase the laminar flow and decrease turbulent flow, you remember your Reynolds number. Most important thing to keep the patient in a laminar flow is to clear secretions, as secretions induce turbulence. Try to use larger size ET tube if possible. Avoid ET tube blockages, prevent kinking and biting on the ET tubes. You can reduce the flow rate, which can reduce the Reynolds number by increasing the I time. You can also use Heliox, which has got much lower density, and use in cases of severe obstruction. You can decrease length of the respiratory circuit by minimizing the unnecessary addition to the circuit. So for example, here we see a corrugated tube between the endotracheal tube and the ventilator, and if it is not needed, you can connect the ventilator directly to the endotracheal tube. You can also shorten the endotracheal tube if it is too long. Non-invasive mechanical ventilation can reduce work of breathing by using CPAP or expiratory PAP in a bilevel, and they can reduce both elastic and resistive work of breathing by preventing atelectasis, reducing pulmonary edema, and treating sleep apnea. They can also be used to counter auto-PEEP in COPD. One of the problems with non-invasive is inability to handle secretions. Invasive mechanical ventilation reduces work of breathing in many ways, of which sedation is possibly most important. Whenever you intubate these patients, all the oxygen that was being required by the respiratory muscles during the work of breathing is now diverted towards more important organs. You can use PEEP more effectively on a ventilator to reduce both elastic and resistive work of breathing. You can control flow rates and I time much more effectively on a ventilator. You can clear secretions. One of the things to remember is if the patient has severe hypoxemia, try to avoid ventilator settings in which patient is allowed to do work of breathing, for example in autoflow, PRVC mode, etc. If you're dealing with severe hypoxemia, you can use sedation or paralytic to decrease work of breathing or prevent ventilator asynchrony. Vent asynchrony and agitation cause increased work of breathing and can cause hypoxemia. Sedation and paralysis can be used after you have optimized the ventilator settings. However, these medications come with their own set of problems, so always evaluate risk and benefits before initiating these. In summary, work of breathing is a body's response to some underlying pathology. Try to treat the underlying pathology and make the work of breathing more efficient. Avoid suppressing work of breathing in an unintubated patient. One of the ways mechanical ventilation work is by decreasing work of breathing. Elastic work is reduced by treating underlying cause, preventing atelectasis by using PEEP, treating auto-PEEP, positioning like head of bed elevation, proning, etc., draining large pleural effusions, treating extrapulmonary causes for stiffness, and increasing the respiratory rate rather than the tidal volumes. Resistive work, on the other hand, is reduced by increasing airway diameter, secretion clearance, reducing flow rate, keeping the flow laminar, and decreasing the density of the gas. These are some of the principles by which you can help your patient reduce work of breathing and manage them more effectively.